Hey guys, today we are going to discuss about the management of diabetic ketoacidosis, DKA. Now, the first step you will do if the patient of DKA is diagnosed, that is secure 2 IV line, one for insulin infusion, one for fluid. Now, first of all, you have to replace the intravascular volume. That you will do by giving 1 liter 0.9 NaCl over 30 to 60 minutes. Now, fluid of choice will remain normal saline 0.9%, right? Then in the next hour you will still give 1 to 2 liter, and until patient is stable and urine output is increased, right? That will replace the intravascular volume. Now, to replace total body water deficit, we have to give 0.45% NaCl, which is half normal saline, and you will infuse at the rate of 150 to 500 ml per hour. So then, because of giving fluid, patient will have great amount of urine and the blood osmolarity will dip down, right? So the blood glucose level will also go down, and if the blood glucose go down by 250 mg per deciliter, which is stated here, then you have to add dextrose 5% at 100 to 200 ml per hour, right? So now you will ask a basic question, that we are doing so much to decrease the blood glucose level, and sir, you are telling us to give dextrose 5% in a patient of DKA, diabetic patient. So I'm not saying that illogically. The logic behind this is, understand that there is an extra cellular compartment which is blood vessel, and there is another compartment which is intracellular compartment, which are your cells. Let's take an example. They are your brain cell, right? Now, if the blood glucose will drop drastically, the osmolarity will decrease. And compared to your cells have high osmolarity now. So the fluid will shift from extracellular to intracellular compartment. Now, if this occurs in brain cells, it will cause cerebral edema or osmotic encephalopathy, right? So we have to give dextrose when blood sugar dips down 250 per mg per deciliter. Now the fluid is replaced over 12 to 24 hours. Patients are generally depleted 3 to 6 liter in decay. You can also give RL, which contains potassium. So before giving RL, you need to check serum potassium level. And also before giving insulin, you need to check potassium level. Now coming to remember the fluid given in decay, we have to remember the rule of 3. Whenever the patient is admitted, in first 3 hours, give 3 liter of fluid. In next 6 hours, give 3 liter of fluid. In next 12 hours, give 3 liter of fluid, right? So this is for your you can remember easily. Now current medical diagnosis and treatment book 2023 states, do not give more than 5 liter fluid in 8 hours. Now what it will do? It will cause ARDS, adult respiratory distress syndrome, in lungs. Now that is the most common cause of death in decay in adults, and in pediatric patients it is cerebral edema. So remember, do not give more than 5 liters fluid in 8 hour of time period, which can lead to increased risk or can cause ARDS, acute respiratory distress syndrome. So we have to check SpO2 of patient. we have to add an pulse oximeter to the patient and check the oxygen saturation level, right? Now, what is the target of blood glucose level we have to decrease in DKA patient? That will be 50 to 100 mg per deciliter in per hour. Every hour your target is to decrease 50 to 70 mg per deciliter. If it does not decrease, if we decrease blood glucose level drastically, what will happen is that the blood glucose will go down, the serum osmolarity of extravascular compartment will go down, and the fluid shift will occur from ECF to ICF, and that can cause cerebral edema. Now, moving forward to the second important step, which is electrolyte management. Now, pay attention here. In DKA, if initial potassium is less than 3.3 milliequivalents per liter, do not give IV insulin until the serum potassium is supplemented. And if the potassium goes up by 3.3 milliequivalents per liter, there will be good time to give insulin. But if it is less, do not give insulin. Why? Due to risk of severe hypokalemia. Now, what does insulin do? Insulin sends potassium into the cell from your blood vessels. So, if the serum potassium is low, it will further decrease the potassium and can cause hypokalemia, right? Now, there is a scale-based system to give supplement potassium or to do not give. If the serum potassium is more than normal, like 5.5, if it is good in the range, then do not give potassium. If it's 4 to 5.4, add 20 milliequivalents per liter in IV fluid. If 3.3 to 3.3, add 40 milliequivalents per liter. Right? Sodium is generally artificially low because of hypoglycemia. So we have to correct the value of sodium. We will know the sodium will be corrected by serum sodium level, which have to be added by the value which will come from constant value, which is 1.6. Get the blood glucose level, insert here, minus by 100 divided by 100, and you will get the corrected sodium level. So patient might be hyponatremic, but you have to correct the sodium, so you don't need to treat it, right? Bicarbonate is generally not allowed or suggested in DKA, but there are some conditions where we give bicarbonate in DKA, which are severe acidosis. If the pH goes down then more than 7, then we should give, but it should be stopped when the pH is normalized. Severe loss of buffering capacity when serum bicarbonate is less than 5 to 10 milliequivalents per liter. If the acidosis induced cardiac or respiratory distress occur in the patient, we need to give bicarbonate. If there is severe hyperkalemia, we need to give bicarbonate, right? So moving forward to the ECG changes in potassium levels, because in DKA patient you need to do an ECG. So if there is a patient with hyperkalemia, you will see in a moderate cases that there is a wide flat P wave, a widened QRS, and tall tented peak T wave, right? In extreme cases, there is no P wave and there is inversion of T wave, right? Which can lead to sine wave pattern further hyperkalemia stages. Now, don't confuse this with hyperacute T wave, which are round from top and seen in MI, early changes. Early changes MI have tall T wave, but they are round from the top. But in hyperkalemia, there is tenting of T wave. They are pointed peak T wave. Why this is important? Because MI can be the trigger for diabetic ketoacidosis. So you have to differentiate it. If there is hypokalemia, we will not say hypokalemia in this case. We will see hypokalemia, right? Hypokalemia. Why? Because the PU will remind us that there are U wave in hypokalemia, which can also be merged with T-wave inversion in extreme cases, and there can be a falsely, we say, QT interval prolongation, because this U wave and T wave forms a confusion in students, right? So there are U waves in hypokalemia, not hypokalemia, right? So these are the changes. If there is hypokalemia, treatment is giving potassium, and if potassium is high, hyperkalemia, you need to hold the potassium. In hypokalemia, patient can have these arrhythmias, SVT, afibrillation, atrial flutter, right? Now in hyperkalemia, there is a stages wise ECG changes. From 5.5 to 6, there will be tau-tented T wave. 6.5 to 7.5, there will be loss of P wave. 7 to 8, there will be a widened QRS complex, and 8 to 10 will produce arrhythmia, sine wave pattern, or asystole. Worsen life-threatening condition is VTAC. Now for treatment, hold the potassium if you are supplementing it. Give IV calcium gluconate to stabilize cardiac membrane so they don't develop ventral tachycardias or serious tachyarrhythmias. Add insulin because we have learned that it causes shift from extracellular compartment to intracellular compartment. So that will dip down the potassium level. Do not give it in DNS because it's a diabetic patient. Give it in NS. Now moving forward to the insulin treatment. Now we will give insulin a dose of 0.0 to 0.15 unit per kg. But first we will give it bolus, not in infusion. Why? To sensitize the insulin receptor or the upcoming insulin, we have to sensitize by giving bolus insulin so that the insulin resistance a bit lowered due to giving of bolus insulin. So our next infusion will work. Now it can be given in bolus form as IV, SC or IM if there is no IV access. Now then we will do a continuous IV infusion via infusion pump. A standard infusion is 100 unit regular human insulin, which is human actrapid in India. 100 ml, 0.9 NaCl, 1 unit per kg per hour is the rate of infusion. Now we will continuously monitor the blood glucose level, which is every 1 hour, right? And if the target range of our blood glucose level lowering is 50 to 75 mg per deciliter per hour. If this 3 consecutive stable reading we get, we can shift from 1 hour monitoring of blood glucose to 2 hour. And if the infusion rate is changed in any course of our treatment, then we have to again shift it to the 1 hour monitoring to be safe. Step is adding dextrose 5% to IV fluids. When BG is less than 250 mg per deciliter, DKA goal of blood glucose is 150 to 200 mg per deciliter. We have to maintain this by giving dextrose 5% until the NN gap is closed. Now, when we will change the insulin IV rate, IV insulin rate is lowered if the blood glucose is drastically lowered, is lower than 100 mg per deciliter per hour in any 1 hour period. Why? Because of risk of osmotic encephalopathy. If the blood glucose is lowering less than 50 mg per deciliter per hour, which is our target, we need to up the insulin drip rate by 50% per hour, right? Now, condition where we will give subcutaneous insulin. If the treatment is going good, NN gap is closed, we will give subcutaneous insulin. Soda bicarb is more than 15 milligrams per liter, then we will give subcutaneous insulin. When patient is able to eat, patient is stable, we will give subcutaneous insulin. Moving forward, stop the insulin drip after all the following are done. When we will stop the IV insulin. First thing we will do is giving a short-acting insulin, Aspart or Lispro, subcutaneously, which will be, the dose will be twice the hourly IV rate. Example, if we have IV rate is set to 5 units per hour, then what we will do is give 10 unit short-acting insulin subcutaneously when the IV infusion is running. The second step is give long-acting insulin, NPH or glargine, subcutaneously at 0.2 to 0.3 unit per kg or home insulin dose. But remember, if you are giving NPH, which is also an intermediate acting or long acting insulin, we will give it in a divided dose Q8R, right? And ensure the patient has a meal and is eating, because it can cause hypoglycemia. Now, why we are giving subcutaneously insulin before stopping the insulin drip? Because the insulin half-life of regular insulin is only 5 to 9 minutes. Failure to give subcutaneous insulin may result in rebound hyperglycemia and ketosis. Why? Because IV regular insulin has very low half-life, 5 to 9 minutes only. So if God forbid your patient gets cerebral edema as a complication of DKA, what you will do? Initial treatment: as soon as cerebral edema is clinically suspected, give mannitol 0.5 to 1 gram per kg IV over 20 minutes, and repeat if there is no initial response in 30 minutes to 1 hour. Then we have to reduce the limit of fluid we are giving to the patient to 1/3. If mannitol does not work, we can give hypertonic saline 3%, 5 to 10 ml per kg over 30 minutes, which may be alternative to mannitol if there is no initial response to mannitol. Elevate the head of the bed, right? Intubate for airway protection and impending respiratory failure. Hyperventilation to PCO2 less than 22 mm per Hg has been associated with poor outcome, and it is not recommended. After treatment for cerebral edema is initiated, a brain CT should be obtained to rule out other possible causes of intracerebral deterioration, especially thrombus or hemorrhage. So this was the management of DKA. Thank you.